Today I'd like to talk to you about partial knee replacements, and I'm going to discuss some of the differences between a partial knee or a resurfacing knee and what's more commonly performed, which is called a full knee replacement. A normal knee has cartilage at the ends of the bone, which act as a very low friction bearing. That allows the knee to move essentially without pain. Now inside the knee there's several ligaments, and those ligaments, in addition to the shape of the knee, allow the knee to move in a very complex way. People tend to think of it as a simple hinge joint that bends back and forth, but the truth is a knee is extremely complex. It does a lot of very subtle rotation motions, sliding motions, pivot kind of motions, and all of those things are what we perceive as being a normal knee. So anytime we change those, we get the perception that something is different in our knee. Here you can see on the screen two very different types of implants. The one on the right is a traditional total knee implant. We cut the entire top part of the shin bone off, cement in a metal tray, and at the end of the thigh bone, we machine and put on a metal sled, that fits both on the inside and the outside portions of the knee. And there's a very large plastic bearing that goes between those. That's a total knee replacement, and very effective at getting rid of pain. Very effective because it's essentially resurfaced all the portions of the knee that can cause a problem. The concern, though, with the total knee is that you have eliminated the ligament that's in the center of the knee. Those are called the ACL and the PCL. And you've also put in components that are shaped differently than our original knee. And as a result, a total knee moves different. Now, most people will tell you they get very good pain relief from it, and most people say they're happy. But frequently what we hear in the office is, "Doc, I feel pretty good, but what? But it feels different than my regular knee. But it feels tight. But it moves, I can't put my finger on it, doctor." And the reason we see this is because we've changed the biomechanics of the knee. The analogy that I would give to you here is that it's kind of like when you have a shoe that you put on. When we go ahead and resurface a total knee, that shoe is very different. You might be a size 8, but if you put someone else's size 8 shoe on that they've worn, it will feel different. Your whole foot will get different signals, and that's what happens with the knee. It gets different signals as well. When we do the resurfacing, like we see on the left, we keep all the ligaments intact. We don't cut portions of the bone that aren't involved, and as a result, the knee moves more like your natural knee does, like it did before your surgery. The total knee is a good operation. One of the concerns, again, is that it doesn't move like a normal knee. Some of the other issues that we deal with are larger incisions. We have to make a longer incision to get this implant in. We have to cut through more of the muscles. We do see that the recovery for a total knee is longer than with a partial knee. We also see there are more complications that we have to deal with, things like infections and blood clots and wound problems with the total knee. Some of the advantages, again, of the partial knee is that it can be done with a smaller incision. We do these as an outpatient. You don't have to spend the night in a facility. We see much less blood loss, a faster recovery. The range of motion is different. With a partial knee, people are able to bend the knee farther back, and it allows them to kneel on the knee, which is certainly important for people of certain faiths and people of certain job occupations. And people will tell us their knee feels more natural. Here's a model of a knee that is ideal for a partial knee replacement. The inside is worn out. We want to replace that. But most importantly, the ligament next to it has to be perfectly balanced. If we put a component in that's too big, the ligament will be stretched too tightly. If we take too big of a cut of bone, or don't put a big enough component in, the ligament will be too loose. The Zimmer partial knee replacement system helps us perfectly balance the ligament of the knee every time. Here we see the original measured cut or thin wafer of bone being taken off of the inside of the knee. We use a very special jig to make very accurate cuts and remove this damaged portion of what we call the tibia or the shin bone. We then use a sizing guide to select the right size implant for the shin or the tibia bone. We make special holes for it to fit, and this device that is slid in here is called our tensioner. Here we see the tensioner perfectly balance the inside of the knee prior to making any further cuts. We mark the center of the femur or thigh bone for perfect alignment, and then we use a special router that cuts a groove like a record player in the thigh bone. This groove maintains the tension on the ligament on the inside throughout the full arc of motion in the knee. That groove is then used to reference all future reaming or routing so that we get a perfectly matched trough to accept this thigh bone or femoral component. Here we see the thigh component being sized. We want to make certain we're using just the right radius of curvature. We drill several holes to allow locking pegs for the implant to be fit. Once it's prepared, we use trial components to test the balance throughout the extension and flexion of the knee. Here we see it's nicely balanced, so we take our trial components out, and then we use bone cement to place our final components. That's the tibia tray, that's the femoral skid, and here we see our little plastic bearing being put in and snapped into place so it's locked. After this, we again test the range of motion to make certain the knee is nice and stable. Prior to surgery, you will have a visit with one of our physician assistants. The physician assistant will meet with you and review your medical history, as well as discuss which medications need to be stopped before surgery. They will discuss strategies to decrease the risk of blood clots, which may include things such as aspirin or a very strong blood thinner, and the use of a portable leg pump. Finally, they will review the home care that will be set up for your after-surgical treatment, as well as prescribing pain medication for you to obtain prior to your surgical date. Please remember on the night before surgery not to shave any part of your body, as this can increase the risk of infection. Also, do not bring any jewelry, rings, or valuables with you to the surgical center. Finally, no food should be eaten for at least 6 hours prior to your procedure. On the day of surgery, have a responsible person drive you to Synergy Spine and Orthopedics Center. It's located near the corner of 12 Mile and Mound Road in Warren, Michigan, 5504 East 12 Mile Road. This is what the front entrance of the facility looks like. After checking in, you will be assigned to a bed in the preoperative area. The nurses will begin preparations by attaching a series of monitors that will measure your heart rate, blood oxygenation, and your pulse. An IV will be started. A series of medications will then be given to you. This includes an antibiotic to decrease the risk of infection, as well as Celebrex, which is an anti-inflammatory medicine, intravenous Tylenol, which is a pain medicine, and Lyrica, which decreases nerve pain. This cocktail is designed to help keep your pain to a minimum. Next, your surgeon will visit you in the preoperative area and confirm the operative site by placing an X on the region and signing his initials. This is done for safety. You will then have a discussion with the anesthesiologist.
Hello, my name is Steve Rotter. I am an anesthesiologist here at the Synergy Center. I'd like to go over some of the issues with anesthesia, as well as what your experience is likely to be when you come here for your surgery. What we do first is we talk to you in great detail about your medical history, and then we plan an anesthetic, which is appropriate for you and the type of surgery you're having. After we obtain that information, we take you to an operating room. We put on various monitors that look at your blood pressure, your heart rate, your breathing rate, and how much oxygen is in your bloodstream. We will always be there with you the entire operation. The anesthetic will go as follows. The first thing we will do is give you medication in your intravenous that will render you unconscious in a sleep-like state. You will feel no pain, you will be asleep the entire operation, and you will wake up at the end of the operation. While you are asleep, we will be giving you anesthesia gases, and that is administered either through a mask-like device or with a breathing tube, depending on what operation you're having and what your medical problems are. At the conclusion of the surgery, you will wake up, you will go to a recovery room, and you will be taken care of there by recovery room nurses. There are some risks with anesthesia. It is a very safe procedure, but there are some risks. Some of those risks include nausea or vomiting. There's a risk of a sore throat. There's a risk of an allergic reaction to some of the medications we use. Those are very low risks, though. Even rarer risks include dental damage or damage to the mouth or gums. There is also an extremely rare chance of having an unusual or unplanned allergic reaction to some of the medications. There is a very low risk of having an airway infection or airway problem. The overall risk of anything serious from anesthesia is less than the chances of winning the lottery. We're talking about 1 out of 500,000 or less. Things to remember prior to coming to Synergy for your surgeries: we ask you to not have anything to eat or drink at least 6 hours prior to your surgery. This is because patients who have an empty stomach are much less likely to have nausea after surgery, and also it is important to not have anything to eat or drink because there is a chance of having a bad outcome from anesthesia in the event that food or liquid comes from the stomach up the food pipe into the windpipe while you are asleep. This is very important. People have anxiety or fear of the anesthetic or surgery prior to coming. We are aware of that, and we will have medications to treat that.
Finally, it's time to go to the operating room. While we're getting things ready, I'd like to show you how the equipment is prepared prior to the operative procedure. Your instruments are hand washed and prepared in very specific trays to keep them organized. They are then placed into a machine called the autoclave, which uses a combination of steam and pressure and heat to completely sterilize the equipment. It is then wrapped sterilely and stored in our core, and finally it is brought into the operating room to be opened for surgery. Here we see how the leg is prepared and sterilized and draped for the operative procedure. During the operation, the reamers are used to cut depth grooves and to machine the end of the knee. It does in fact sound quite a bit like a machine shop when we are milling the bones to allow them to accept the perfectly fit implants. Here I am testing the balance of the knee as I take it through a full arc of motion. Diagrammatically, we can see the inside of the knee has been replaced and the ligaments are nicely balanced, not over or under tensioned. At the end of the case, we infiltrate special long-acting anesthetics into the operative wound. These anesthetics act a bit like a pomegranate. They have an anesthetic bound around a seed, and the anesthetic takes about 3 days for it to completely leach out into the surroundings. This gives us a very nice, long-acting pain control. When combined with our TLC cocktail, these injections allow people to have 3 days of good pain control and to be able to go home on the same day as the surgery is performed. Following wound closure, we then return to the post-op or recovery room, where nurses monitor the patient to make certain they are fully recovered and comfortable. Here an ice pack is applied to the wound to help with pain control. Once the patient has fully recovered, we go to the X-ray suite to shoot an X-ray of the knee to verify that the implant is in good position. After you are fully recovered, the nurses will prepare you for discharge. You will be given a handout with information about aftercare, your follow-up appointment, contact information for the home care agency, and instructions on how to use your leg pumps. Even though you are capable of walking, we will use a wheelchair to wheel you out the patient exit. Your driver or friend who's with you will pull their car up and we will help to load. For the first 2 weeks after surgery, it is critically important to wash hands. Hand washing is the #1 way to reduce infections. That means that not only you, but your friends and family member who visit must wash their hands before they touch you. In addition, walking is critical. The more you walk, the more you keep blood flow to the leg, the more you reduce the risk of blood clots, and the stronger you make the muscles. Be certain to take your aspirin or blood thinner and use your leg pumps for at least 18 hours a day. At the end of this segment, we will show a video on how to use the leg pumps properly. Remember also to take pain medication as directed by your patient handout. John Paul Home Care will be contacting you to come to your home and help with dressing changes, initial physical therapy, and mobilization. At approximately 4 weeks after the surgery, your wounds will have healed up completely, and you will be able to bend and flex your knee. This is an example of a patient who was approximately 4 weeks after his partial knee replacement. We close with a 4-minute segment detailing instructions on how to use your leg pumps.
My name is Tim Leahy. I'm with CarePoint. We service this pump for DVT prophylaxis. The reason you're wearing this pump is there is a period of inactivity following your total joint replacement. That inactivity of muscle action, which normally keeps blood flow going in the deep veins of the lower leg, this pump takes over for that lack of muscle action by gently massaging that muscle to keep blood flow going. You'll need to wear this at least 18 to 20 hours a day for it to be effective. Included in your pump kit, which will be delivered to your house, is the box, the pump and case, the sleeves, the AC charging adapter, non-slip socks, and protector.
Here we see how the leg pump is set up. A strap fits over the shoulder, and a clip is used to hold the tubes to the belt. This prevents any tripping. Protective socks are placed over the leg, and the pumps are then connected in the fashion such that the up is pointed towards the torso and the D is pointed down towards the leg. Once this is assembled, you can begin to ambulate. A tube will go to each one of the leg pumps. You may wear any shoe that is comfortable for you.
It's very important that you ambulate and walk around as much as possible. The best prevention in blood clots is mobility. So the more you're walking around in conjunction with wearing this pump, the more you'll be protected. To eliminate the trip hazard, please wear the clip. It can be affixed to your garment. To turn the pump on, push this button here. The mode button, you want to make sure it's on double leg. If it's not, push the mode button until it's on double leg. The pump begins pumping. It alternates sides. Troubleshooting. If the pump is only pumping on one leg, check the mode button. As you can see, it's set up on the blue light for single leg. You need to change it to double leg by pushing on the mode button, and it'll switch to double leg. It's a good idea when you're sitting around watching a movie or reading a book to keep the charger plugged in. To plug the charger in, simply push it into the bottom port and the green light goes on indicating it's charging. A CarePoint brochure will be provided to you which describes the use and return of the pump as well as contact information.